Good afternoon, everyone. This is David Rich. I'm in the KCC1 administrative suite, and also we have Dr. Dennis Charney in his office. We have Dr. Florian Kramer, a very prominent virologist who is going to be joining us today. And as always, Dr. Gopi Patel, infection prevention lead for Mount Sinai Hospital and stewardship lead for the health system. So we're going to welcome you to this town hall. Today we're going to be addressing just general issues related to COVID in the very beginning of the conference, but we're going to spend the majority of the time talking about new COVID vaccines, including developing news even from today, and leave plenty of time at the end for your questions so that we can answer them appropriately. Dr. Charney, would you like to make some comments?
Yes, I'd like to add my welcome to everybody, our staff, faculty, students, scientists, to the town hall. I know you're working really hard. We're in the fight again. I know you're under stress. I'm going to talk at the end about what is available to all of you to help you get through whatever stress you might be feeling. But I 100% appreciate what you're doing clinically, research-wise, teaching our residents, teaching our students during this time. So again, welcome, and I look forward to your questions.
Very good. So to get started, I just want to remind everyone that you can submit your COVID-19 questions using the Q&A feature in the Zoom app. And we have already incorporated some frequently asked questions in this presentation. The first thing to show is the graph that we've shown many times before in the town halls, which is the number of admissions in the Mount Sinai health system from the very beginning of the crisis in the middle of March through the present. And what you can see is that we had that massive spike in the spring that we all remember and hope never to repeat, and a period of very low but never zero activity during the summer. And then again, starting really from the very beginning of October, we've seen what was initially a very small second wave. But if we blow up the slides, what you can see here is that as the fall has come about and people have moved to more indoor activities and gatherings such as the Jewish holidays, the beginning of reintroduction of children into schools, Halloween and Thanksgiving, that we're seeing a further increase, not just in the nation, but also in our region. So this is the Mount Sinai specific view. And so now Dr. Patel is going to make some comments about infection prevention.
Thanks. We just want to remind everyone that we expect all of you, when providing direct patient care, to wear your eye protection. Everyone should be wearing a mask, including our patients, as tolerated eye protection for all patient encounters. Next slide. Also, we are moving to the Halyard Duckbill N95 respirator. If you see the link below, and we'll send it out in a future broadcast, please make sure you're fit tested on the Halyard Duckbill N95 respirator. It's now the Mount Sinai Hospital primary N95. Next slide. We just want to remind everyone, we're well aware that the numbers of patients with diagnosed COVID-19 are increasing in our community. You've all seen this slide several times during the pandemic. At this point, irrespective of someone's test results, we do ask that you utilize an N95 respirator along with eye protection if you're involved in any of these procedures. This has been communicated to our units and can be used extended use for the duration of the day if you are performing any of these procedures listed here. In terms of exposures, obviously, as the community numbers have gone up, we've seen increased numbers in our staff as well. When we do exposure investigations, what happens in the community, even if it involves healthcare workers, is a 10-minute duration of close contact within 6 feet, irrespective of masking. In the healthcare setting, we're expected to wear appropriate PPE and our patients should be masked. When we look at this along with our EHS colleagues, we're looking at 15 minutes of more of close contact, one or both parties not masked, and not wearing eye protection if the patient is not masked. N95 respirators and eye protections are recommended for patients and interactions where there's aerosol generating procedures involved. For staff. And what we're finding is as we're looking at this and doing contact investigations, we're still having congregation of staff in the setting of eating. So please make sure you're mindful of distancing yourself from your colleagues while you're eating, especially in those designated areas where we've put the number of individuals who are allowed to be in that room during meal times. Next slide. This has come up quite a bit recently. We know it's been well publicized that the CDC has altered their recommendations for self-quarantine after a documented exposure to someone with known COVID-19. Currently, the New York City Departments of Health and Mental Hygiene and the New York State Department of Health, their guidance hasn't changed, although they're reviewing this closely. So for now, if you are told you've been exposed to COVID-19 and are asked to self-quarantine, that's 14 days from the last exposure to the individual that you were exposed to.
Thank you, Dr. Patel. Now for clinical and research updates, wanted to demonstrate and show everyone what has been happening at Mount Sinai Hospital over the last several months. So this is Mount Sinai specific data looking at the number of patients that are admitted on any particular day in the spring, and then this bluish cyan color in the summer, and then moving into the fall. And we split it up into March to June, July to September, and October through the early part of November. And the reason is that if there is going to be, sadly, a mortality from COVID-19, that usually doesn't occur until several weeks after admission, as we know that deaths lag hospitalizations. And so we don't show any data that are less than 30 days old. So looking at that, we see that the age is pretty much the same. We haven't seen younger patients specifically. The mean hospital length of stay, however, has come down from 11 to 10 to 9 days on average, which is a great thing. Mechanical ventilation has also diminished dramatically, and if we average out, what's happened in July through present, probably only about, basically about half or a little bit more of the number of patients get intubated. Despite that, we still provide critical care services to a large number of patients, but the number of patients in the ICUs that are intubated has been diminishing over time. Probably the most encouraging news is that the very early rates of mortality at 20% dropped to 5% over the summer, but it does seem to be, if not an uptick with numbers this small, certainly we could have a sampling error, but we certainly still see that this is a very scary and deadly disease with a measurable mortality rate, probably somewhere between 5 and 10% for hospitalized patients. And the other very encouraging piece of information is when we look at the number of people who are discharged directly to their homes, not to a skilled nursing facility or a rehab facility, we see that that has been steadily increasing over time. Another thing to talk about in terms of advances that have already been put into place, really for the entire health system, but initially being performed at Mount Sinai Hospital, is we are administering the new monoclonal antibodies that have been released from the Lilly and the Regeneron companies. The Lilly drug is called bamlanivimab, and the two drugs that are combined as a cocktail for Regeneron are casirivimab and imdevimab, but I'm told that all infectious disease doctors are calling it BAM and Cassie if you don't want to use the names of the companies. And as an academic center, I certainly hope we will try to use the generic names if we can. There's a limited weekly allocation to the states based upon 7-day hospitalization rates, but thus far we have not had a problem with a number of patients exceeding the supply at present. This is approved only for outpatient treatment for patients 12 years of age and older, and they have to be at high risk of progression to severe disease. So this would be in patients over 65 or in younger patients with specified risk factors, and symptom onset less than or equal to 5 days before the being considered for treatment. For anyone who is listening who wishes to refer a patient, there is information on the website, but we have an email as well, COVID therapeutic referrals at mountsinai.org. And there was a broadcast email that was sent out on December 1st. If anyone needs more information, we will always provide that. The other very promising news is that we will begin randomized prospective trials of hyperimmune globulin at Mount Sinai Hospital and soon throughout the entire health system as soon as next week. The two major categories are studies looking at the safety, tolerability, and efficacy of hyperimmune globulin in the treatment of adult hospitalized patients. For those of you who are not familiar, hyperimmune globulin is a concentrated antibody product that is purified by a fractionation process from plasma donated from people who have recovered from the illness, so-called convalescent plasma. If convalescent plasma is like a shotgun, hyperimmune globulin is like a laser beam in that it is very specifically limited to the antibody fraction of the plasma, and it is something which can deliver a very high and consistent dosing. And also, since it's no longer a transfusion, since it's a purified product, it doesn't require that we know the patient's blood type. And the second major study will be in healthy volunteers looking at the pharmacokinetics, that is the behavior of the drug in the body, and the pharmacodynamics of hyperimmune globulin in adults with and without SARS-CoV-2 infection. So now we're going to be really treated by having some information from Dr. Florian Kramer. Dr. Kramer, for those of you who don't know, is one of the most prominent vaccine experts and virologists in the nation, and is responsible for having designed what is the most accurate worldwide antibody test for antibodies to SARS-CoV-2. So Dr. Kramer.
Thank you very much, Dr. Rich. So I wanted to say a few words about vaccines. There's a lot of hope about the vaccines that are most likely starting to be administered next week, but there's also a lot of worries about them. And so I would like to try to give some more information and to address that. As you all have heard, these first vaccines that will be hopefully licensed through an emergency use authorization are RNA vaccines. And what these vaccines are geared towards are inducing antibody responses to the spike protein on the surface of the virus. You see a virion here on the left side. These little spikes on the surface, that's the spike protein, and that's the protein that actually is used by the virus to attach to our cells. Now, if we have antibodies that bind to that protein, they neutralize the virus, and the virus cannot infect us anymore. And so the goal is to really induce these antibodies. Now, how does this RNA vaccine technology work? Basically, the information that is needed to encode this spike protein is taken from the virus. So just this isolated sequence, not the whole virus genome, and that's biochemically synthesized as messenger RNA and then packaged in little fat particles. And they are then used to vaccinate. So this is an intramuscular vaccination. And at the injection site, your cells are taking up this RNA. And the cells are using this information to now make this spike protein, and only the spike protein, no other components of the virus. And then you mount an immune response against this spike protein. You make these antibodies, and these antibodies are protecting you from getting infected. For many of you, that might sound a little bit like science fiction. This is a new technology, but I wanted to make a few points here. First of all, mRNA, or messenger RNA, is a normal component of cells. In fact, all of our cells have it at high concentrations. It's actually the way of how the cell gets information or blueprints for making proteins out of the cell nucleus, where our genome sits, into the cytoplasm, where the ribosomes are, these little machines that make protein. And the other important thing to know is that this mRNA cannot go into the nucleus and integrate in our genome. So there is no concerns about changing our genome with these vaccines. And the third point that I wanted to make is that if you get a virus infection, your cells also do similar things. The virus forces your cells through providing a lot of this RNA to make all kinds of viral proteins, and it takes over the control of your cells. So what you look at here is a technology that basically provides your cells with the information to make one protein that the virus has on its surface, and then you make antibodies against this protein, and these antibodies protect you. Next slide, please. I also wanted to talk a little bit about vaccine development. And a lot of you know that vaccine development usually takes a lot of time. And there's a lot of worries that the development of these new vaccines was rushed, which is certainly not the case. So what you see here is the pipeline for regular vaccine development. And we are going through that, for example, now with the universal flu vaccine that we are developing at our department. And this is going through many different phases. You start to work on this in a research laboratory, in a design and exploratory phase. This might take a few years. Then you try to get funding. Usually you need a commercial partner to further develop this into actually the clinical pipeline. There's a lot of process development involved, a lot of preclinical and toxicology studies. And then you start a phase 1 trial, which is a small trial where you look first at safety and to a certain degree of how well the vaccine works in inducing an immune response. Once that is done, usually after 1 to 2 years, and if you have funding, if you can secure funding to actually move the project forward, you might go into phase 2, which is a little bit of a larger trial with maybe a few hundred individuals, which tests different doses, for example. And if that works out and you see the immune responses that you want to see, you have to stop and really think hard if you want to go into phase 3, because phase 3 trials are very expensive, often $300 million. So you have to be sure at this point that your vaccine is fantastic, that it does what it needs to do, that you still have a market for the vaccine, and only then you go into phase 3 trials. And it's very hard to finance these trials. Usually finding the funding for these phase 3 trials takes more time than actually doing the phase 2 trials. And then you file a biologic license application with the FDA. They review that, and only then, once the vaccine is licensed, you start to produce the vaccine and distribute that. It's a very long process that's really limited by funding and by financial risk. Now, for SARS coronavirus 2, the situation was different. There was a lot of experience from SARS coronavirus 1 from 2003 and also from MERS. We knew which protein to focus on. We knew how to modify the protein to make it an excellent immunogen. The processes to develop these vaccines were basically taken from other vaccine processes. They were not necessarily optimized, which doesn't impact negatively on the vaccine, but might impact negatively of how much vaccine can be produced. A lot of this optimization was then done in parallel with already clinical development. Phase 1 trials were already started in March, and they were done in an adaptive design. So a phase 1 started once it was clear that the vaccine was safe. The phase 1 trial was expanded, more people were enrolled, and after an interim analysis of safety and immune responses, that phase 2 trial, phase 3 trials were already started in July. And in addition, or in parallel to starting the phase 3 trials, vaccine producers started to make vaccine at risk. This is something very unusual. No company would do that in a normal situation, but it was done in this pandemic. Again, because all the financial risk for them was removed. And now the first data came in from these phase 3 trials. Actually, in terms of efficacy, we have seen the final data already from Pfizer and from Mrna. These companies now asked for licenses, emergency use authorizations actually, from the FDA. What the FDA does there, they look at the safety, they look at all the safety data, they look at efficacy data, and they only need efficacy data for a few weeks. because they also consider the situation, and that's what an emergency use authorization is for. They also take into account that we're in a pandemic and that 2,000, often I think now almost 3,000 Americans die every day. And based on that, they make a decision if this vaccine can now be used in the population. And that's the point where we are right now. And so I just wanted to stress that safety was really well investigated here, but that the financial risk was taken away, and that really sped it up. It's also not the first time that these RNA vaccines are tested in clinical trials. Here's just a list with clinical trials that have been started already in 2013, the first one with RNA vaccines. And actually Mrna is now moving a CMV RNA vaccine into phase 2 because it was successful in phase 1. So this is ongoing. It's not the first time that humans receive RNA vaccines, and this is just for infectious diseases. There's many other cancer vaccines that are also in development. So there is considerable experience with this vaccine platform. Next slide, please. And just to give you an overview of the two candidates that are really close to getting an emergency use authorization, we have on the one hand the product from Mrna, which was tested in phase 3 trials in 30,000 participants. So half of them got the vaccine, the other half got the placebo. This included 37% of participants from communities of color. They recorded almost 200 cases in the whole trial, 185 in the placebo group versus 11 in the vaccine group. You already see here that the vaccine is working. And they even had 30 severe cases, and all of them in the placebo group. They calculated an efficacy of 94.1%, filed an EUA application on November 30th, and they will have a meeting with the FDA on December 17th to make a decision about the authorization. Pfizer did the trial in about approximately 43,000 individuals. Mount Sinai was also part of this trial. They had 42% participants from communities of color. They also had a separate analysis for the age group 65 to 85 years old. They had 170 cases of COVID-19, 162 in the placebo group versus 8 in the vaccine group, 10 cases with severe disease, 9 of them in the placebo group, and they calculated an efficacy of 95% overall and 94% in the group of 65 to 85-year-olds, which is great because this is really our high-risk group. They filed their EUA on November 20th, and they actually have their meeting with the FDA tomorrow. So we'll know very, very soon if the FDA is happy with moving this forward. One point that needs to be made here, these vaccines had very good safety profiles in these clinical trials. There were no severe adverse events. What has to be said, though, is that we see reactogenicity. You might know this from getting the flu shot. There might be injection site pain. There might be some muscle and joint pain. There might be some headache. Fatigue is very often associated with the vaccine. And there might also be some elevated temperature. And this is usually seen after the second dose, not so much after the first dose. And I just wanted to show one more slide, which really demonstrates very well how these vaccines work. This is from the FDA document from Pfizer. And you have two lines here. The red line is basically the placebo control group, so individuals who got injected with saline. And the line that goes up reflects COVID-19 cases in this group. So you see there is a constant, there are constantly COVID-19 cases, the number of cases goes up. And the blue line are vaccine recipients. And what you see there is that initially the two lines trend together after the first vaccination. But then approximately 10 days after the first vaccination, the lines separate, and you see very, very few cases anymore in the vaccinated group. And that basically happens after the immune response after the first vaccination kicks in. So this is a beautiful example of a vaccine that works really, really well. Although there is indication now that it already works after the first shot, I want to stress it's very important to also get the second shot because the second shot might be very important to get high affinity antibodies, and it might be very important to get long-lasting immunity. But again, when I saw this document yesterday and I saw this graph, this is really as good as it gets with vaccines. And so with that, I'll hand it back over to Dr. Rich.
And thank you so much, Dr. Kramer. That was a beautiful presentation. And now Dr. Patel is going to talk to us a little bit about the prioritization of vaccine and how, with direction from federal, state, and local authorities, we are going to decide how we're going to administer this at Mount Sinai.
Thank you. So the ACIP, which is part of the CDC that includes private citizens, reviews all of this data and has been meeting for quite some time and more frequently to talk about the importance of these vaccines and who should get these vaccines first. Once they make recommendations, every state and every jurisdiction who's receiving an allocation of vaccine will then further define who those first priority groups are. We do know the recommendation from public health authorities at the federal level and also from both the state and the city have recommended that healthcare personnel, which is inclusive of clinical and non-clinical individuals who are in patient care areas, and staff and patients in long-term care facilities, which were hit so hard during this pandemic, should be offered vaccine first. We're waiting to fine-tune this information based on recommendations from New York State and New York City. And it really depends on how much vaccine is allocated, not just to the jurisdictions, but then to individual healthcare settings. As more vaccine becomes available, we will expand, not just here at Mount Sinai Hospital and the school, but throughout the health system, who is eligible to sign up to get vaccinated. Next slide. You have to understand, we've all heard anywhere between 6 to 20 million doses of the Pfizer vaccine will be made available by the end of the year. But in the United States, there's 21 million healthcare workers. In New York City alone, there's thought to be about 300,000 healthcare workers. And as you expand to the populations that are really important to maintaining sort of the infrastructure of New York State and New York City, as well as healthcare, you can imagine that this is going to be difficult as these allocations come out. How do you get to all of these people? All of you have heard about difficulties in storage and distribution of these particular vaccines due to the cold chain requirements. We're not going to get into that here, but we're happy to answer questions offline. But really, we're looking as a group and as a system, and we're including individuals who are part of various task force to maximize benefits and minimize harm, promote justice, and mitigate those health equities that we saw throughout this pandemic. Remember, as more vaccines become available, and it's important for lots of different vaccines to become available to mitigate those issues with cold chain. You can imagine in rural areas, they're not going to have those negative 80 Celsius freezers to store these vaccines. They're not going to have an army of pharmacy experts to help make sure that we maintain these vaccines at the right temperature. And we're not going to have all of those individuals who are going to be helping us vaccinate our colleagues and our healthcare workers. So more to come, but this is where we are today. Next slide. So these are some frequently asked questions, and I'm going to ask my colleagues to help answer them. I don't know if Dr. Rich, you want to take this one?
Yes, certainly. It's always a tough thing to decide how to manage vaccinations. And it's very clear that with such a very new set of vaccines that will be emerging in the weeks and months to come, and the very unique situation we find ourselves in, that no one is planning at this time to make COVID-19 vaccination mandatory. And that is a very important thing to remember, that we will follow the recommendations that come from public health authorities. We will not use vaccination to affect work assignments. Our attitude is that we believe that when the right authorities recommend them, that it's important that everyone who is willing to get a vaccine and is in the right priority group receive the vaccine. And then our hope is that people who are reluctant for whatever reason will see that their colleagues and others that they respect are receiving vaccines, that they're doing well with them, that they are developing antibody responses. And this is going to be the only way we're going to move towards the end of the pandemic. So it is going to be something which is challenging for many people. We understand that. I was making rounds yesterday in the emergency department in several of our units where patients are receiving care for COVID, and the staff have divergent views about what vaccines represent. And some people are justifiably a little bit scared of what this new world means to everyone. And so our hope is that we will provide, both through forums like this and just by showing examples, that we will provide the support, the knowledge, and the reassurance that will enable people to get vaccines that want them, but we will not make them mandatory. It is possible that at some time in the future, public health authorities may change their opinion about this, but we are nowhere near that stage within the months to come. Dr. Patel, do you want to make any additional comments about that, or Dr. Kramer?
I think, you know, again, one, we're waiting for more allocations and we're waiting for the recommendations for our public health authorities. I do think it's really important, and this has already come up in the Q&A, and I just want to sort of state this clearly, that we do want you to stick with the vaccine that you are offered. So if you do elect or are eligible to receive the Pfizer vaccine, that you continue to complete the course of the Pfizer vaccine and not sort of opt out and wait for another vaccine to come. What's really encouraging is what Dr. Kramer showed, is that with the mRNA technology, the efficacy data that we have seen to date and the safety data is equivalent for 2 different mRNA vaccines. And that's really encouraging that you know, those are the 2 vaccines that are coming first, and more to come, but that's very encouraging. So if you're offered and eligible, we would really recommend taking us up on it. But we realize everybody should be able to make their own choice. Right now, a lot of people need a little bit more information, and we totally understand that.
Very good. So Dr. Patel will take this one as well in a moment, but I think the answer to the previous slide was no, and the answer to this slide is yes. If I had COVID-19, should I get vaccinated? Definitely. We have no idea how long natural immunity will last, and every single person has a slightly different antibody response to COVID-19. Remember also that the clinical trials of all of the vaccines thus far did not exclude those who had baseline antibodies. They weren't even measured in some of these trials. So in order to vaccinate a large population, we will not be able to antibody test everyone, and not all antibody tests are created equal. The one developed by Dr. Kramer happens to be amazing, and we are very willing to test patients at Mount Sinai, our employees and our faculty, our students, anyone who needs to have, for their own peace of mind, a knowledge of their own serology status to COVID-19, we will provide that. But we do not believe that that knowledge should influence your decision to get a vaccine. Dr. Patel, do you want to expand on that?
We do know in the trials that they did test people on entry to make sure they did not have COVID-19. And in terms of a PCR test, we also know that individuals who had a history of a diagnostic test, meaning a PCR or an antigen test, that was positive for SARS-CoV-2 virus or infection were excluded. If you look in the data that was released yesterday, about 3% of individuals in the trial did have baseline serologies that were suggestive of exposure or previous infection with COVID-19. So they either did not know that information or it was just they were asymptomatic. So for right now, our recommendation is, again, if you are offered vaccine and you are eligible, to please proceed with being vaccinated.
Very good. Dr. Patel, why don't you talk about this one, please?
Sure, and I would love some help from Dr. Kramer as well. So these trials were not looking specifically at asymptomatic infection. So that is an unknown at this point. So they looked at individuals, and they, in that graph that Dr. Kramer showed, was specifically looking for individuals with symptomatic infections. And many of the symptomatic infections were between doses 1 and 2 in the vaccine arm. So that wasn't, this goes to, yes, there was a nice trajectory for the antibodies in that graph that we all saw yesterday and fell out of our chairs. But I think that's important, that you need to get the second dose. And in the details from the FDA, it does look like there were several cases between the first and second dose. And also, it's going to take time, as I said, to vaccinate enough of the population to get to the point which hopefully by the end of the summer next year, we'll be able to be in the room together without masks on. But for now, we do ask, in the setting of being vaccinated, to continue to take those precautions that we've always asked you to take. Wear your mask, social distance, wash your hands, and wear appropriate PPE.
And I think it's important to remember that when you're in public, when you're with other people, there's no way that other individuals could know that you've been vaccinated. There's no way they could know whether or not you've mounted an adequate immune response. And therefore, as responsible members of society, it's still very important for all of us to be participating in the public health measures. And when someone who gets a vaccine decides not to be masked, it helps I should say, I'll rephrase it. I'll say it actually hurts the ability of our public health authorities to maintain a level of compliance with masking and with social distancing that is so important, because it's going to be a long time, as Dr. Patel said, before we can vaccinate enough people to achieve herd immunity. Dr. Kramer, anything you'd like to say about this?
Yeah, I can add that, the efficacy that we see is amazing, but keep in mind that all these things, vaccines, reduce your risk. It doesn't reduce your risk to zero. And specifically, if you have situations where you have a lot of virus still around, as it is the case now, specifically if you work with patients who shed a lot of virus, it's always good to have additional safety gear on. When we work with infected animals, for example, that have influenza infections, we have a flu shot, but we still mask up and we still try to protect ourselves in addition to that. So keep that in mind. It's a very significant risk reduction, but it's still good when there's a lot of virus around to mask up.
Thank you very much. As everyone knows, the health system has spent a lot of effort and been a lot of intellectual input into creating reliable vaccination information and resources. And the MountSinai.org about COVID-19 vaccine information, basically on our website, is something that all of us can go to. And many of the questions that we've addressed here in this talk and others that we'll get to in the Q&A section are all on this website. So for example, when will a vaccine be available? How do I know a vaccine is safe? If I had COVID-19, should I get vaccinated? I hope we've answered most of those questions already, but not everyone will have the time to watch a town hall. And so this is a very good method of also disseminating that information throughout our health system and even to those outside of our health system. Dr. Patel, any other comments about the online information?
No, we are very much trying to keep this up to date, as you know, and as you can tell, it is changing and changing very rapidly. So please keep coming back to the site. We do have experts who are offering their opinion and answering questions. There's videos being made with individuals that you know and you trust. And Dr. Kramer has some Q&As available on this website. So please visit this website. Many individuals will be coming to your areas and having sort of Q&As with you. We want to make sure we're answering your questions. And I do want to make sure if you have specific medical conditions for which you're concerned about these vaccines, to talk to your primary care providers. And I know throughout the Q&A, there's individuals who are concerned about their own medical conditions, although I'm sure Dr. Schaefer will ask us some important questions that globally have been asked throughout the Q&A.
Very good. And Dr. Charney is now going to talk to us about the very important effects of COVID has had on our community and the great concerns that we have about behavioral health and just what we can do to support our frontline healthcare workers.
Yeah, thank you. Yeah, we know that many of you have been under a lot of stress, both at work and at home. For example, we know in the general population that the rates of anxiety and depression has more than doubled. And we feel it's our responsibility to take care of our own. We conducted a survey back in March, April, and May of our frontline healthcare workers. And we found that, the level of anxiety and depression and burnout among many of you was high, about 40%. And so, based on that, we have offered a number of things to, help you with that, which I'm going to go over in a second. But we also want to see where you are right now. Exactly what is the level of stress and depression you are feeling, so we can make sure that we are offering, what you need to deal with that. So we have essentially released a second round of this survey, and you will receive an email link to complete that survey. And we really encourage you to do that, to complete the survey, so we can know how you're doing, and we can provide you the resources you need to deal with any stress, anxiety, or depression you are feeling. So our Office of Wellbeing and Resilience has put together a lot of resources to help you. You can go to our website that can tell you what kind of crisis support, one-on-one support, group support, spiritual care, and so forth is available to you. Please make use of those resources. And here's another slide that talks about all the things that we have available, including that we developed a center for stress, resilience, and personal growth, where we will provide without cost, what you need if you are dealing with pretty serious forms of depression and anxiety. And you can see on this slide, we got lots of other programs that are available to you. Again, please make use of them. And this describes our Center for Stress, Resilience, and Personal Growth. We will provide to Mount Sinai staff, faculty, and students no-cost resilience training, individual support and consultation, and personalized referrals. Please contact the center to learn more about how we can support you. Again, thank you for all that you're doing, the courage, the bravery, the dedication, to our patients, to the research that's so necessary. But if you're feeling stress and anxiety and depression, please make use of our resources, and also please fill out the second survey so we can know how you're doing. Thank you.
Thank you, Dr. Charney. I just want to take a moment before we get to questions and answers to highlight and really recognize what's happening at Mount Sinai Hospital, where all of our staff are working so hard. To emphasize what Dr. Charney said, it's not easy for our patients, not easy for our staff, not easy for our families. And here we have examples of staff that have gone out of their way, even at this difficult time, to really show that they have caring and empathy. I'll begin with the discussion of Chaplain Rachel Ventin. Chaplain Ventin was approached by a Mount Sinai Hospital staff member who was dealing with a personal issue. The chaplain immediately stopped what she was doing, searched for and found a quiet place to offered privacy for a conversation with the distressed employee. She provided meaningful real-time pastoral counseling, as well as helpful resources to the staff member in need. The staff member was searching desperately for help, and Chaplain Ventin did not hesitate in providing help at a moment of crisis. What a shining example of Mount Sinai values. The next person to highlight is Collado, a medical clerical associate in the Dubin Breast Center Radiology Group. We received a call from a patient who was very pleased with her interaction with Collado. The patient said that was very helpful to her, not only with getting her an appointment as soon as possible, but also helping calm her anxiety. The patient felt defeated after making several attempts to get an appointment, but with professionalism, empathy, and attention, the matter was resolved by this exceptional employee. And finally, Janelle Page, a patient care associate in Guggenheim Pavilion 10 East. The GP 10 East staff would like to acknowledge our amazing patient care associate colleague, Janelle Page. She is a testament to what great teamwork and kindness looks like. Her respectful and calm manner has not gone unnoticed by the staff. We would all like to recognize her for the wonderful contribution her presence and professionalism has added to the workplace on 10 East. Thank you, Janelle. And with that, we'll move on to questions and answers. Dr. Sarah Schaefer, infection preventionist at Mount Sinai Hospital, will be presenting the questions to the panelist group.
Thank you, Dr. Rich. There's a lot of great questions that have come in today so far, and I'm going to start with one of the more frequently asked questions. It was, what about pregnant women? Are we going to recommend the vaccine? Will they be allowed to be vaccinated? What's our recommendation for pregnant women?
So this is a great question, and it's actually come up quite frequently, not just here, but at other sites in our health system and probably every day while we've been rounding. Pregnant persons were not included in the clinical trials. And in the clinical trials, the individuals of childbearing potential are asked to defer getting pregnant for 1 to 2 months after the second dose. There were individuals, now that we've seen the data, that did become pregnant during the trial, and no adverse events have been seen, but it is early and there are a lot of unknowns. We've been looking toward our public health authorities, the ACIP, and some of our experts in OBGYN here at Mount Sinai and through the school to offer us guidance. We do know the Society for Maternal Fetal Medicine has recommended that pregnant healthcare workers do get vaccinated. We do ask that if you are pregnant or planning to become pregnant, you speak to your primary obstetrician and start having those conversations with them. As soon as we know more information, we will get back to you. We do know persons of childbearing potential are a large percentage of our healthcare personnel. So if you're planning to become pregnant soon or are pregnant, start having those conversations with your primary providers, and then have those conversations with your partners or others or whoever you're planning with to figure out whether you can allot the time to get vaccinated and then work on starting your family.
Thank you, Dr. Patel. Dr. Kramer, I think this one's probably for you. A lot of people have been asking this novel mRNA technology, how long does it last in our cells? How long is it in our bodies? Is it something that stays around for a while?
Yeah, there's very good data on that, actually. So RNAs and mRNA is very unstable. And so this has been looked at very closely in all kinds of animal models. This is very short-lived. So you can imagine that the RNA stays in your cells for a few days. These cells produce this spike protein for a few days, and after a few days, it's gone. It just gets degraded. As I said earlier, these are components that your cells are using for many different purposes anyways, and they just degrade them.
Thank you. This is possibly also for you or for Dr. Patel. There's been a lot of questions about some of the news reports coming out of the UK today with some severe reactions to the vaccination that they started this week. Not sure if you have any thoughts on that and how we'll react to that.
Sure. This was a little bit unexpected when we could see what Pfizer put out. Hypersensitivity reactions were fairly rare. We're waiting for some more information. Just so you know, whenever we have vaccination pods, and we've done them for years on site, our nurses and our staff are aware of what anaphylaxis looks like, which is the most severe of hypersensitivity reactions, and are prepared. So we're waiting for some more information. If you are allergic to vaccine components, if you have that history, please again discuss it with your primary care provider or your allergist. But we're looking for more information, as this was a sudden report from the UK early this morning. Dr. Kramer, do you have anything to add?
I just wanted to add, I looked into the clinical protocol from the Pfizer trial this morning. So people with allergies, food allergies, for example, were not excluded from the trial. Pfizer probably needs to look at what percentage of individuals had allergies that were in the trial, but they know that none of these side effects in the trial. So it's certainly not something that will happen very commonly. It didn't happen in the 20,000 individuals that received the vaccine as part of the trial.
Thank you. Moving a little bit away from the science of it and into logistics, Dr. Patel or Dr. Rich, there have been a lot of questions about within our hospital, how are we going to prioritize and how are we going to disseminate the vaccine and the information regarding where you fall in that priority scheme?
I'll start. There's an emerging consensus that seems to be both at the federal, city, and state level that we have to prioritize two key groups of individuals first. One, it does not affect Mount Sinai directly, and that is residents of congregate facilities. So that is a resident of a nursing home, technically also a prison, but nursing homes are, of course, the areas of greatest concern because the age of the individuals that are in those facilities. And the second major group is healthcare providers that are at high risk of being infected by COVID-19 in the workplace, or I should say by SARS-CoV-2. And to that end, we know that the people that are most exposed in the hospital would be those who are working in intensive care units, respiratory therapists, those who are providing direct care to patients in our nursing units. And I would also emphasize that this is not just physicians and nurses and advanced practice providers. This is also individuals that are working in environmental services, our housekeepers, our transporters, our patient care associates. So we feel very strongly that the entire clinical team in units where there is a high risk of exposure should be at the top of our priority list. However, I will end these comments by saying we may get very specific instructions from the city and the state. And so we're awaiting to see what those specific instructions are before we give the definitive answer of who will be invited to receive the vaccine in what order. Dr. Patel, anything else?
Sure. We actually have been discussing with other health systems as well, because we know you do. And I think it's very important. We're looking sort of generally who is potentially exposed to aerosolizing virus, especially in the unknown setting, right? So a lot of emphasis has been placed on our emergency medical services. So we have EMS workers that work throughout the health system, our emergency department as a zone, so inclusive of all the staff that are dedicated to that zone, whether they're EVS, respiratory therapy, our radiology group that's specifically housed in that zone, and working with those leaders and those line managers really to start having these conversations. Everybody has different questions, and so I think this has also come up in the questions. How are you getting this information across? This is a start, but we are going place to place, unit to unit, group to group, to huddles, through Zooms, to start offering information and meeting people where they are with this. So we don't know how much we're going to be allocated as a hospital, as a school, as a health system. We will probably find out more information late Friday and into this weekend, but we are committed to being transparent with all of you. If we get a lot, that's great. If we get very few doses, it is likely as a health system we'll start in that emergency department, ED, emergency medical service zone because of the unknowns in that space.
Thank you. Shifting back to Dr. Kramer for a minute, there have been a lot of questions about how the antibody protection that you get from the vaccine is different from natural exposure, or if you get infected with the virus. And then also piggybacking on that, how long the vaccine protection will last. You know, will we need to be vaccinated every 6 months, every year?
All right. So there are differences between what you get through vaccination and what you get through natural infection. What we consistently see with vaccination is very high titers in serum. Almost everybody who gets vaccinated has these high titers. What we see with natural infection, there's a lot more variability. There are some people who have lower titers. There are some people who have very high titers. So that's a major difference. It seems that the immune response to the vaccine is very uniform. So that is important to keep in mind. The other point is how long lasting is it? There is now data from Mrna over 4 months, and we see that the antibody responses look normal. The kinetics look normal. They seem to be long lasting, and there is no reason right now to believe that these antibodies would just go away. It's actually very reasonable to assume that they will stay relatively stable and that will have protection for a few years. Now, it's unclear at this point if there need to be booster doses, but I think I need to say very clearly that it's very unlikely that we end up in a situation with where we are with influenza, where we have to give a vaccine every year. It might be that every few years you need to get a booster, like with other vaccines as well, but we do not expect a situation where this will become an annual vaccine.
Thank you. Are there are a lot of different questions coming in with different specific chronic conditions, but in general, people are asking about if they have an immunocompromising condition, which I'm sure many of our employees do. Is there any recommendation? Were these types of patients included in the trials? Do you have an opinion on whether they should get the vaccine?
Dr. Patel, we're depending upon the infection prevention expert.
So many immunocompromising conditions in individuals who are on immunomodulator therapy. So let's say someone with inflammatory bowel disease who's getting Remicade or infliximab, a lot of those individuals were excluded from the clinical trials. A few things, a lot of the societies that take care of these patients are having robust conversations about what the recommendations should be. I think we could think about it twofold. Will it cause harm? Likely not. Will it cause the immune response and will those individuals have the robust immune response we'd like to see? We don't know, and I'm going to look to Dr. Kramer to answer that question. I think this is the idea that people refer to as herd immunity, right? You want as many people who can get vaccinated while you try to protect those who might not be able to get vaccinated. Think of the youngest of children and those who are immunocompromised, mostly because they cannot mount an immune response, or at least as robust of an immune response as those who can. People with underlying comorbid conditions were definitely included in the trials. Diabetes, high blood pressure, mild liver disease, mild kidney injury. And I think it's important to make sure that those individuals get the information that they need. If you are someone, and as I said before, if you have an immunocompromising condition, we do have many healthcare workers who are transplant recipients. Please start talking to your providers. They are already talking amongst themselves and their societies and their experts to find those answers. And I think trials are coming. They're just not there yet.
I can add to that maybe from what we know from some of the other vaccines. It's true that in some patients that are immunocompromised, the immune response might not be as strong, or it might even be not measurable. But in many cases, it has been seen that if these people get vaccinated, there is still a degree of protection there. It's usually much better than not getting vaccinated. And as Dr. Patel said, it's unlikely that these vaccines will do harm if you have an immune system that does not work optimally.
Thank you. And this question, which might end up being our last, this was directed directly at Dr. Kramer, but I'm actually going to open it up to Dr. Charney and Dr. Rich and Dr. Patel too. When your turn comes up, would you get vaccinated?
I think all of us, I'll make a stab here. Yes, for all of us.
Yes,
I might
when
add,
my turn comes.
I did volunteer for the Pfizer trial, so I'm enrolled in that trial. I do not know if I got the vaccine or the placebo, but I took that risk a little bit earlier based on the data that I had from the phase 1, phase 2 trials and based on the animal data. So I can certainly answer this with yes.
But didn't you measure your own antibodies with your assay?
I did not want to unblind myself. This is not what scientists should do.
And that's a true dedication to science. However, I will say that for those of us who are not part of the trials, that there's a lot of enthusiasm among our leadership to receive the vaccine. I certainly believe that all of us in leadership would not want to jump the line in terms of not standing up for a vaccine before we would reach the normal prioritization. So as a cardiac anesthesiologist who makes rounds in a hospital, at some point I will be told that it's my turn, and I will be very pleased to start a new sport I'm referring to as synchronized sleeve rolling with as many people who'd like to get vaccinated with me as possible. This is a chance for us to really take ownership of this, to do something personally to address the pandemic. And I certainly hope that based upon what you've heard today in this town hall and what we see in the weeks to come, that despite the concerns and despite the newness of it all, that we will feel comfortable enough to participate in this very important program. And hopefully we will get the result that we want, which is to have a safer work environment for those of us who are treating patients with COVID-19, and also the ability to protect our families and our other loved ones that we come in contact with, and finally reach a point where we can see the light at the tunnel at the end of this terrible pandemic. Very good. Any other comments from the group? Dr. Charney?
I would second what you said. And I want to again emphasize, that we know that you're feeling stress. Some of you are exhausted. We're here to help. So make use of our resources, and we will continue to educate you about the vaccine as new information comes out.
It's very good. So we will come back. We will have another town hall. Clearly, this is a rapidly evolving situation. So in an appropriate period of time, let's say perhaps 2 or 3 weeks, as we start to see vaccines become available and we see what the horizon looks like and we understand city and state requirements, we will continue to have that dialogue and that education, and questions that were not answered today, we will look at them and we will adjust the website to the frequently asked questions, and we will continue appropriately, not to overburden people's inboxes, but appropriate broadcast emails, especially as we've seen from our System Chief Medical Officer, Dr. Lopatian, who I think has been a remarkable communicator to our community during this crisis. So thanks, everyone. I think we've reached the end of the hour, or in fact, a minute or two over. This has been recorded, and likely tomorrow we will send out a broadcast email with a link to this town hall. Feel free to share that with other colleagues. We regard this as information that we're very proud of what's going on at Mount Sinai. Nothing is to be hidden. And feel free to share it and to educate and to get the information out there so people really understand what we're doing as a health system to approach this terrible disease, and to be on the forefront of science and research as we attack this in a way that we think that very few others in the world have been able to do. So we're very proud of what's happening at Mount Sinai. And despite all the problems that we have, we can also look to our successes and be very, very engaged with our community as we learn from each other and do the right things to protect ourselves and our loved ones.